Well, I'm going to talk to you all about stress nuclear. Basically, a lot of methodology and a little bit of a lot of hodgepodge of things that I thought were very important to know in the lab. A lot of my slides are right. You'll see the logos on some of them. You know, these were presented at a recent board review. So I think any of what you'll see today is fair game for the boards. And it's really for the nuclear techs that are here, this is bread and butter, you know, what we do every day. And for the fellows who want to know, how the lab runs a little bit, this is a great, great review. And anybody who wants copy of the slides, just email me, and I'll get that to y'all. I'm going to get going because, as usual, I always apologize. I have way too many slides than I usually need, and I need to get through some of this. So first thing we should know about is the ischemic cascade. Y'all heard a little bit about this. And what is this? This is when a patient has ischemia or poor blood flow to an artery, there's a sequence of events that happen. And believe it or not, angina, the complaint of chest pain, is actually the very last event. So what happens first? You have perfusion abnormalities. These perfusion abnormalities are what nuclear imaging tries to detect. So we believe we're very sensitive because we identify the first abnormality of the ischemic cascade. After that, you have diastolic dysfunction followed by systolic dysfunction. These are techniques that look for wall motion abnormalities such as stress MRI or stress echo. Finally, the treadmill test where you find abnormal EKG, ST segment changes, and then finally the presence of angina. So this is again the ischemic cascade and some different imaging techniques where we can identify abnormalities during ischemia. So we're going to talk a lot about nuclear imaging today and specifically SPECT imaging. So what are the basic, bird's eye view of what happens? We're going to inject a radiotracer usually after stress. This isotope is hopefully going to go in proportion to flow to the heart and be extracted by living myocytes. This will then be retained in the myocyte, and then these radiotracers will emit photons as they decay. This will be detected as gamma rays by these cameras, and finally you'll have the creation of an image in proportion to actual blood flow. So this is kind of the bird's eye view of what happens in nuclear imaging. Now there's two very, very important principles for y'all to understand about myocardial perfusion imaging, specifically nuclear myocardial perfusion imaging. First is you need to create heterogeneity of flow. And I'll expand upon that more, but just remember that you need to there needs to be some sort of stressor, either exercise or pharmacological, and you want to create disparity of flow between the stress state and the rest state, because that's how you're going to bring out differences in flow between regions that are normal versus those that are served by a stenotic artery. And then finally, you need a radionucleotide. This radionucleotide has to be deposited in the heart in proportion to coronary blood flow, and it also has to be extracted by living myocytes. So those are two very important principles. I'm going to be hitting upon it multiple times. So principle number one, you're using stress, we have to create flow disparency. Why do we need to do this? So this is a very old study, Dr. Lance Gould on coronary physiology, and what it pretty much shows is that for resting flow, which is this bottom curve, okay, maybe I should use my mouse, which is this bottom curve right here. At rest, a stenotic lesion will not result in hypoperfusion until it's an extremely severe lesion, usually more than 90%. Whereas in stress, when you increase coronary blood flow, usually by the time you have some drop off around 50% of coronary blood flow, but really you can see the most steepest portion of this graph. Once you hit about 70%, that's when coronary blood flow really starts to decrease markedly. So hence why we need stressor agents to create this flow disparency between stress and rest. And this hopefully, these next sequences of cartoons hopefully will kind of drive home the point. This is a patient in the resting state All right, you have an artery that's served by stenosis here and a normal artery without any blockages. Remember, as long as this lesion is not, let's say, more than 90%, coronary flow here in the resting state in both these territories will be normal. So you should get equal deposition of radiotracer in the heart. Whereas look what happens when the patient is stressed. And when you're stressed, you now create a flow disparity. There's a pressure drop across the stenosis. And you can see in the region where you don't have a stenosis, you have, a significant amount, you have radiotracer that's deposited in proportional to blood flow. Whereas in the region now, if this stenosis is greater than 70% in the region that's served by a stenotic artery, you should now theoretically have a drop in coronary blood flow, and therefore a drop in the amount of radiotracer that is deposited in the myocardium. So when you look at these images, this flow disparity now will translate into different radiotracer uptake, and you will be then able to see, as you evaluate the images, regions, a hypoperfused area from a normal perfused area. And let me just take that one step further. So if you can imagine where this is the resting state, and let's say we're depositing radiotracers in proportional blood flow. If you have a stenotic artery here and normal arteries here at rest, you should have equal deposition of radiotracer. Whereas look what happens in the case of stress. If this is a significant lesion, you are going to have a significant discrepancy of the amount of radiotracer that is deposited in the regions of the heart, comparing normal to those that are comparing to the stenotic artery. And so when we frame normalize this image, meaning you just kind of reset everything to the hottest pixel, you can kind of see now how our nuclear images show you a relative hypoperfusion. Because now when you reset the image and you kind of frame normalize, the normal myocardium will be bright, whereas anything that was served by a stenotic artery will have less coronary blood flow, less radiotracer uptake, and then less gamma photons to emit, less, and a hypoperfused image. So this is kind of the principle, very, very important principle of why we need stress to create this flow disparity between normal and stenotic arteries. How do we increase blood flow? These are techniques you know every day. Adenosine dipyridamole, probably y'all are now young enough where you've not seen these agents being used. We mostly use regadenosine. We'll be talking about some of those agents. There's of course Dobutamine, and of course there's exercise. What I'd like to point out is that exercise in general gets you about 2 times normal blood flow, whereas these vasodilators such as regadenosine increase blood flow almost 4 to 5 times normal resting state. Now, second principle. Now we've created this flow disparity. Now you want to be able to make sure that you deposit radiotracer in the myocardium in proportional to flow. So the second principle here is that you really have to have radiotracer uptake and extraction in proportion to flow. So if we look here, this is just a curve of radiotracer uptake in the myocardium in proportion to myocardial blood flow. And as you'll notice, as you increase flow, whether it's by exercise or pharmacological, an ideal radiotracer will have a proportionately increase in radiotracer uptake. Unfortunately, in real life, this does not happen. And you have something what's called, with our radiotracers that are available to us, such as thallium, at least the SPECT agents, such as thallium and the technetium agents, there's a phenomenon called roll-off, where as flow increases, unfortunately, this leads to less radiotracer deposition. It's not in proportion to blood flow. So why is this potentially important? Well, hopefully this slide will kind of explain that to us. If you remember in the normal resting state, you kind of get equal deposition of blood flow because the stenosis is not severe enough to affect resting blood flow based on coronary physiology. However, in your stress state, you can imagine that if you have this roll-off phenomenon where your radiotracer now is not able to track with the severity of flow. If you have less radio tracer deposition, and also because of this roll-off phenomenon, you can actually underestimate the size and magnitude of the stress perfusion defect. And this table kind of shows you how in a normal artery, let's say you get about 3 units being deposited, whereas when you have a radio tracer that does not relate in proportional to blood flow, if the flow was increased to 5 times, it should have been 5 times worth of flow. But because you have a stenotic artery and you have this roll-off phenomenon, you have you have deposition that is almost similar to what you have in the normal myocardium. So when you look at an image, you may not be able to tell relative perfusion differences. And this is just as the studies have been done. I won't, for the sake of time, I won't spend too much time on it. But if you compare to the gold standard, which is microsphere flow, these radio tracers, especially agents such as technetium, can demonstrate less perfusion abnormalities than agents such as thallium. Okay, so that's kind of like the principles behind what we do. Now let's get a little bit into the day-to-day clinical aspects of nuclear imaging. So stress testing, the exercise treadmill testing, this is a test we like to do. Why do we like to do it? We learn a lot from when patients exercise. We learn about the symptoms that they're having when they're exerting themselves. We can see blood pressure responses. We can see how much they're able to exercise. We can see EKG changes and whether they're having arrhythmias or not. We can see their ability and how long they can exercise. So it's an extremely important and useful technique to stress patients. One important note to note is that you want to get your patient's heart rates up to at least 85% of the predicted heart rates. Anything less than that can be lead to a reduced sensitivity of your diagnostic testing. Now, we get a lot of different patients here, and it's important for us to know who are good candidates for the test, who are not good candidates for the test. Really, when it comes to exercise testing, your eyeball test can be very helpful to you. If this is a patient who's acutely ill, they're coming in with unstable angina, they're complaining of chest pain to you, they can't breathe, they're short of breath, they're in heart failure, this is not a patient to be trying to get to run on a treadmill. If they have uncontrolled hypertension, remember with exercise your blood pressure will go up further. So if your blood pressures are already starting at more than 200 over 100, again, this is not the patient you necessarily want to exercise. And there are some issues, even in our own lab on SMIT-19, severe pulmonary hypertension. We don't necessarily want to, again, exercise these kind of patients. Patients who have severe aortic stenosis, this has to be done very, very carefully. We do it, but generally those patients are asymptomatic, and we want to kind of get a feel. But again, it's done under very, very close supervision. And then there's a whole host of relative contraindications, and I know everybody in this lab, this audience here today, has stressed many of these patients. But really the hard contraindications are those who, when you look at them, they don't look right, they're already not feeling well. When you are exercising them, it's often a question, what should I do? Should I let them go? Should I just stop it when they reach their target heart rate, or should I keep on going? Preferably as cardiologists, we want you to let them go as long as they can, because to be honest with you, we learn so much about them, how much they're able to exercise, what are the symptoms that stop them. So for us, we prefer that these patients should be exercised until they stop. But as a person who's observing these studies, what are some signs you should look out for? Obviously, angina that's progressing and getting worse, marked dyspnea or fatigue, if they're near syncopal, if you see they're becoming cold and clammy and starting to sweat, signs of poor perfusion, you want to be very careful. If you're already seeing significant ST depressions with chest pain, I would probably stop the test. Any ST elevations are worrisome for an acute injury pattern. You don't want to continue. Obviously, if they have some SVT or VT, With exercise, again, blood pressure should always increase. If you see a drop in your blood pressure, that can be an ominous sign. Now, just be careful. There's a caveat to that. You know, a lot of times, remember, these patients are running. There's a problem with maybe correct detection of blood pressure. So you have to, either you do it yourself with manually, or just recheck the blood pressure. If the patient looks completely fine and you're noticing, the blood pressure is low, it could just be, the machine is not detecting it correctly. And then again, if you see marked hypertension, we don't want anybody to have a stroke or anything like that. Pharmacological testing. So if you do have some contraindications to the exercise treadmill testing, our backup is pharmacological testing. What are some pharmacological agents that we use? Again, these are things like dipyridamole and adenosine. Maybe some of y'all, again, may not be familiar with these agents. Big drug that I'll be talking about is regadenoson. This is really our mainstay. Dobutamine, again, maybe some of y'all have not seen these agents being used too often. We really don't like using it now if we don't have to. And I'll talk a little bit, I'll spend two slides on it at most. So when should you consider pharmacological stressing? Well, it's easy. They can't exercise. They have some contraindication to exercise, such as those patients who have, that severe symptomatic aortic stenosis. If there's already changes on the EKG, such as a left bundle branch block, those are great reasons, or they're paced. These are great reasons to consider pharmacological stress testing. If you have a patient who has a known diagnosis of CAD and you want to assess for risk stratification how much ischemia they have on current medical therapy, such as beta blockers, that's another good patient to do pharmacological stress testing. And then, a patient who's had a recent MI, and Dr. Mamarian's INSPIRE trial showed that patients who've had MI who are hemodynamically stable, it is safe to use stressor agents. So let's talk a little bit about these pharmacological agents. Now, most of the pharmacological vasodilators work through the adenosine receptors. So dipyridamole enhances adenosine, and adenosine goes ahead and affects 4 different types of adenosine receptors, which are actually located all over the body. And some of some of these receptors that are activated are actually the cause of a patient's side effects. So the particular effect we want is from the A2A receptor, which is responsible for coronary vasodilation, whereas some of the other effects that we don't want are from A1 activation, which causes the AV block, chest pain, tachypnea, the A2B, which is in the lungs and is responsible for the bronchospasm, and then finally the A3, which can again be for bronchospasm or this allergic reaction with these mast cell degranulation. But again, the goal here, the reason we use these agents, at least adenosine and dipyridamole, is to get the A2A effect. And unfortunately, the limitations of those agents is that they activate other adenosine receptors. And this is just a graphic to maybe difficult for us to see on the screen, but showing that these vasodilators, again, there's different adenosine receptors. They work through the ATP cyclic AMP pathways. And what I'd like to show here is specifically that if you look at the A2A receptors, which are the ones that are responsible for vasodilation, regadenoson is specific only to this receptor, and kind of why it's now our preferred drug. It's because it causes vasodilation without many of the other side effects, or at least much less side effects compared to adenosine and dipyridamole. One other thing I'd like to point out on this slide is if you notice, there's some competition for regadenoson or adenosine for the A2A receptor. This competition is provided by caffeine and methylxanthines. So part of the reasons why we prefer patients who have had caffeine not to have, why you tell them, please don't have a cup of coffee or coffee at least for 12 hours before your stress test, because caffeine will go and occupy these receptors and you will not get maximal hyperemia. A busy slide, but all about adenosine. And basically it hits just on a few things that we discussed about. Adenosine is again an older agent. Many of y'all may not even have be familiar with this anymore. It affects all the adenosine receptors. It increases blood flow 3 to 5 times normal flow. It has an extremely short half-life. That was one of the benefits of it. It was gone in half-life was 10 seconds. So if a patient did become symptomatic, we turn it off, count to 10, and they were feeling a lot better. You want to discontinue it again if patients are having side effects. What were those side effects? We talked about it: bronchospasm through the A2B receptor, if they have profound hypotension, or if they have high degrees AV blocks. This was our typical protocol. Generally, these patients had adenosine on for anywhere between 3 to 6 minutes, and radiopharmaceutical was injected at the middle point of it, and then you image the patient about an hour later. And the general effect you'll notice of these agents is you'll notice a slight decrease in your blood pressure over time, and you'll notice an increase in heart rate. And actually, regadenoson works very much the same way, but with regadenoson, you actually get an even greater degree of heart rate than what you see with with adenosine. What are some contraindications to adenosine? The biggest one, of course, is patients the risk is bronchospasm, so patients who are already showing you that they're actively wheezing, such as those who have severe asthma, COPD, active COPD, these are not the patients you want to be giving adenosine to. Obviously, this agent also causes hypotension, so if they're already hypotensive, you kind of want to avoid that. Because of its effects on the conduction system, if they have advanced degree AV block to begin with, again, you want to be avoiding adenosine. And then all the usual things that we're careful with regadenoson as well, that no caffeine for 12 hours, and you want to be off of dipyridamole for at least 48 hours. Now, regadenoson is the agent that y'all are all very, very familiar with, and where we'll probably spend a little bit more time on. This is, again, an agent that is specific for the A2A receptor, and this is the receptor, again, that's responsible for coronary vasodilation. It has very weak affinity for those other receptors. It's very easy to give. This is actually our protocol here. Basically, what you do is you come, it's already pre-packaged in a syringe. It's about 0.4 mics in 5 mLs. You inject it over 10 to 20 seconds. Follow this by a saline flush, and you should have within a short period of time here, almost about within 20 seconds after your flush, you're able to inject your radiotracer. And that would be, so they achieve peak hyperemia very, very quickly. You're able to increase flow almost 2.5 times to 4 times. Half-life, it has several different phases of half-lives, but in general, half-life is not tremendously long. There's one caution that y'all should be aware of, and I don't know if our techs who are here, or maybe our nurses who are here, has anybody seen seizures with regadenoson? Okay.
10,000 times.
Okay, so that is great. So thank goodness, fingers crossed, knock on wood, right? So this is one caution with regadenoson, that they have seen that they're, a potential side effect. One thing for y'all to know is that the treatment for a seizure is not what you would do with side effects with regadenoson. Usually when you have a side effect with regadenoson, you're reaching out for the aminophylline, and they feel a lot better. If you have a seizure, the treatment is not aminophylline. The treatment is anti-ischemic therapy, such as the benzodiazepines. So you want to reach out for the Valiums, the Verseds, and things like that. So just a caveat, God forbid we would ever see it, remember it's not aminophylline. You want to avoid it. It's a very clear finding. It's the benzodiazepines you want to go for. Okay, and then this is just the common side effects. Unfortunately, yes, those patients who deal with regadenoson on a daily basis, they are the same side effects that you have with adenosine, but at a much lower frequency. Dyspnea, headaches, flushing, chest discomfort, A lot of these, again, can be reduced if they're doing a walking reg at the same time, things like that, and letting the patient know in advance they may experience some of this. So what do we do with the patient with lung disease, right? Well, if they're stable, they're not really, actively wheezing, they have mild to moderate asthma, because regadenoson is so specific for the A2A receptors, we recommend using regadenoson on those patients. It's which patients that do we really, get nervous about? Well, it's those patients who come to you who are O2 dependent. I'd be very nervous with them. Those who are active steroids trying to treat some bronchospastic event. Those who, when you examine them, very important to examine them, who are already actively wheezing or have severe asthma. These are not patients you want to be giving regadenoson to, despite its lower incidence of bronchospasm. They're already pretty sick. What do you recommend for these patients? Unfortunately, it's Dobutamine. What about caffeine? So caffeine in the lab, it is recommended that caffeine be held for 12 hours. And the reason is because studies have clearly shown, and these are double-blinded randomized studies, that those, if you repeat a study with caffeine on board, there is a significantly reduced number of segments with reversible defects. So you drop your sensitivity significantly. And it kind of makes sense based on the pathophysiology we know already. So yeah, caffeine can be a big deal, something definitely to inquire about for our patients. Now, what are some contraindications to regadenoson? Again, we hit on a lot of these. Again, patients who are actively wheezing, advanced COPDs, asthmas, on steroids, being treated with, actively on oxygen. If they're already hypotensive, remember this will be like you will get some drop in blood pressure. Caffeine for 12 hours, dipyridamole for 48 hours, and any high degree AV block. Now, one of the things that you've commonly seen is patients being reversed, so with aminophylline. And so what are some, and how do you do this? You can give anywhere between 50 to 250 milligrams of aminophylline, and it can be done as early as 1 minute after the radiotracer injection. So what are some indications for reversal? As nurses and techs and fellows, what should we be looking for? Well, anytime you see a sick patient, right? I mean, if they all of a sudden blood pressure is very low, they've developed advanced degrees of heart block, you're seeing abnormal arrhythmias. These are, if you're seeing evidence of persistent EKGs with ischemia, patient complaining of chest pain, they don't look right. Eyeball test, pallor, cyanosis, cold and clammy skin. Go ahead, go ahead and reverse it. I know y'all are asking, well, what about the chest pains and the flushing? Those are known side effects of the drug. I wouldn't say that's a necessarily indication for reversal, but I think all of y'all have now developed a gestalt of what is kind of a normal experience, and if you feel someone does not look right to you, and I think it's okay, if you had to reverse it. Yeah.
When you said 1 minute, I was always told to wait 3 minutes. That 1 minute would be too soon.
Okay, that's a good question. At least from my reading, and at least from what I've seen, is you can do it up to 60 seconds after the radiotracer. Sure, I mean, the more time you have for this radiotracer to be deposited before you reverse the agent, the better. But I would say, yeah, I mean, if you see a very critically ill patient, they're not looking right, you're going to give it sooner than later, yeah. But yeah, the longer you wait, the more you're allowing radiotracer to be deposited in relation to flow. All right, dobutamine, won't spend too much time. As all the people know, is that this is a synthetic catecholamine. It affects the beta receptors, beta 1, beta 2. So what does it cause? Increase in heart rate, increase in contractility, and therefore increases in blood pressure, all similar to exercise. What is the big indication nowadays? Big indication is contraindications to exercise and vasodilator stress, specifically patients who are mostly O2 dependent or actively bronchospastic disease. When do you not want to give it? Just like similar to those you don't want to exercise, those who look unstable not well. Acute MIs, active heart failures, and things like that. So what are some of the indications that I have seen being used in our labs? Well, if you need echo as the imaging agent, well, guess what? Dobutamine then is the only stressor other than exercise, so that may be one indication. If they're taking dipyridamol, if it's been under 48 hours, this is your agent. Recent caffeine intake, less than 12 hours. If they have, again, significant lung disease or advanced degrees of heart block. Those are the most common patients, very rarely seen, I would say, who could be candidates for dobutamine. Here's kind of how we use dobutamine. It's similar to what you all have seen in the echo labs. It's a kind of gradual, you start at 5 to 10 mics and kind of every 3 minutes increase the dose, trying to achieve target heart rate. You can see the hemodynamic profile effect of it. Blood pressure actually goes up with this agent as well as heart rate, whereas diastolic pressure decreases. And then again, a vast amount of hemodynamic effects are related to, chest pains and palpitations and arrhythmias being the big one you have to be careful of. When should you stop it? Again, patients that don't look sick, severe hypertension has developed. They've already significant arrhythmias such as VTs, SVTs, AFib, severe chest pains with ST depressions, signs of poor perfusion. And how do you, and if you had to stop it and even reverse it, what would you use for reversal? Reversal again is beta blockers. And you can consider beta blockers for patients who are actively having arrhythmias, active chest pain, or those who have uncontrolled hypertension. Now, kind of changing gears a little bit, when it comes to cardiac drugs and myocardial perfusion imaging, I know there's a lot of debate back and forth, what to do with nitrates, beta blockers, calcium channel blockers. Well, it really, honestly, for sure, studies have shown clearly, such as in this study, that if you are on an anti-ischemic cardiac drug, you will definitely decrease your sensitivity for detection disease and actually decrease the amount of ischemia scar you see, and therefore significantly decrease the diagnostic accuracy of the vasodilator stress. So, what should you do? Well, if you have a patient where you're trying to make a first-time diagnosis of the disease, these are patients, then yes, they should not be on anti-ischemic therapy. You should send them back to their room, wait till they come off, those drugs wash out, because you actually want to make sure you're trying to diagnose the disease, and you want, your test's best accuracy to be able to do that. So they should be off of any anti-ischemic therapy. On the flip side, if they already have known CAD and you're using it as to identify their risk based on how much ischemia they may have or something else, a lot of times we do this on medical therapy, because these patients will be, regardless on what your test results show, these guys will be on anti-ischemic medical therapy. So in that patient population, it is okay then to go ahead and stress on nitrates and beta blockers, because you actually want to know their prognosis based on the therapy that they already are on. So again, it's an individual. You do have to think about it a little bit, but the decision is not too difficult. All right, so now let's move on to, we've talked about, how we create flow heterogeneity with exercise, vasodilator stress. We talked a little bit about the different exercise. We talked about a little bit about the different vasodilators. Now let's go back to the second important principle, which was the radiotracer. We need a radiotracer. What's an ideal radiotracer? It has to be, it has to track flow in proportion to blood flow, and then it has to also be extracted by the heart in large amounts. So an ideal agent will do those two things. It'll also have low extracardiac activity. You don't want to see it going to the lung and to the liver. If it could redistribute, that would be great, because then you can do viability assessment. Technetium for us is a very simple agent to use, and it's got very high count activity. So if we could label it to tech, that would be good. And if you could, for the for preparation's sake and being able to administer to our patients, if it could be easily prepared and labeled, that would be helpful as well. So here's another graph of just showing you the different radio SPECT and PET radio tracers that are available to us. What you'll notice is that, you know, the agent, O15 water is the agent that is a PET agent which best tracks coronary blood flow. Unfortunately, it's not FDA approved for PET imaging. And whereas, you know, here you'll notice a combination of both SPECT and PET agents. And what you'll notice is that, you know, if we look specifically at the SPECT agents, you'll notice thallium tracks blood flow much better than the technetium products. So you'll actually have a roll-off phenomenon with technetium, both sestamimide and tetrafosmin, earlier than you will with thallium. So thallium actually tracks blood flow much, much better than the tech agents. So theoretically, your diagnostic accuracy, if it was that simple, should be, you know, we would consider be higher with thallium-based agents. But that's we'll talk more about that. Here's a common rubidium agent, common PET agent that we use, rubidium. You can see that it's kind of in between thallium and the tech agents. And actually, you know, tech agents not so good when it comes to tracking blood flow in proportion to blood flow. So let's now talk a little bit about the individual agents. Thallium, if we look at the advantages, you know, this has been an agent that's been around for a very long time, since the 1970s. You know, with extensive clinical experience. Its advantages are, again, that it tracks blood flow very good. It has this property of redistribution, and hence why we use it with viability imaging. And, you know, it's got reasonable cost. But what are its problems? Why do you not seeing us going for it? Well, the problem it all comes down to is that, unfortunately, with thallium, we often see suboptimal image quality. Why? Because this is a low energy photon. These are 80 keV photons. And so these low energy photons, they can cause, there's a lot of Compton scatter and, you know, other issues where you really don't have an image study that, well, two things are wrong with it. Number one, it's a low energy agent, and then number two, it's got an exceptionally long half-life. And what that means is that if it has a half-life of 73 hours, we actually have to give a lower dose of it. And the reason you give a lower dose is it lasts a lot more in your body, and the dosimetry that you'll eventually get from it could be, you have to stay within certain bounds of radiation that you can administer. So unfortunately, with the amount of dose of thallium that you use, and then these low KE photons that are produced by it, all lead to this suboptimal image quality. And that's one of its greatest limitations and why we prefer tech agents. Tech agents, again, you know, it's got, you know, again, it's got a much higher dose. We give, you know, anywhere between 15 to 30 millicuries. Half-life is much shorter, only 6 hours. So its dosimetry is much, and it's a higher keV photon. It's 140 keV photon. So, you know, you get more escape from the body without all the Compton scatter and all the other phenomena which can degrade image quality. And this, you know, blue side just kind of goes over that. So then, you know, there's the difference between tetrafosmin and sestamimide, but we'll skip that just for the sake of time. So I like this slide because it gives you a good, you know, comparison, side-to-side comparison of thallium and tech, and I'll just try to hit on the major ones. Thallium, again, lower keV photons at 80, lot more scatter and absorption by the body, leading to lower resolution images. Technetium, higher energy photon, 6 hours half-life. You can give a lot higher dose, and that all of it, that results in less scatter absorption, higher resolution images. Both are, of course, you need living cells for it to be uptaken into. You can see the here, thallium has the property of redistribution, which we use to our advantage for viability imaging, and it actually has a much higher extraction fraction by the heart compared to TEC, meaning more of the agent goes to the heart than to lungs, kidneys, spleens, and all the other organs. Okay, and this is just a slide showing you that if you were to look at defect sizes using the TEC agents versus thallium, you get higher diagnostic accuracy again with the technetium agents. Okay, so just a quick question for the fellows or the nuclear techs out there: which agent am I using? I know for the sake of time, anybody want to quickly call it out? Yes, so this is TEC, and the reason is you see lighting up of the hepatobiliary system, which is how this drug is excreted, whereas thallium comes out through the KUB system. So, okay, so now let's move on to a little bit about imaging protocols. So I know you have seen how we do it in our lab, and I'll just talk a little bit about a little bit about how we actually go about imaging these patients. So when it comes to protocols, we have either a one-day protocol or we have two-day protocols. When do we choose which? Well, in general, one-day protocols are used for those patients who you need to complete in one day. So those would be your ops patients or maybe your inpatients where decisions need to be made. The hospital is now held accountable to discharge in a timely manner. All of these things lead you towards one-day imaging. Two-day imaging is really now reserved for those patients who are markedly large, where where you would be concerned that that you would in your one-day studies, one dose is smaller than the other dose. So what can happen is that the study which has the less dose, your image quality may not be very good. So hence, so if you're concerned that you need good image quality on both the stress and rest image in a patient who's markedly obese, let's say, you're looking at the two-day imaging. So what are some advantages? Again, the advantages of two-day imaging are you get good image quality on both images. You have high counts on both sets of stress and rest images. And you can go stress first with this technique if you wanted to. Disadvantages are, you need 2 days, and that, there's some decision making by physicians as well. Single-day protocols, advantages are, of course, you're done in 1 day. There is some challenges. You have to be able to interpret image with two different images with different count densities. The stress and rest will have different count statistics, so that's kind of a disadvantage. One image will be of lesser quality. And then you also have to, so if you're going rest-stress, your rest images will be of poor quality. And if you go stress-rest, your stress images may be of poor quality. What do we do? And so, and these are all, again, theoretical. So this is kind of your classic 2-day protocol. In this particular case, the patient was stressed first. You give a large, you give a good dose of technetium agents. If you've exercised the patient, you can put them in the scanner in 15 minutes. Whereas if you use a vasodilator, you have to wait for about 45 minutes to an hour before you image. You then come back the following day, do your rest injection, and then proceed with rest imaging. Here is our 1-day protocols. This one is with the rest stress, so rest will go first. You give a notice. What you'll notice here is that the second dose that is injected is 3 times that of the first dose. So in this particular case, about 8 to 9 millicuries was injected at rest. You image the patient in an hour. You then wait 3 hours. You let this radio tracer decay, okay? Then you perform your stress test, inject your radio tracer at 3 times the dose, wait 15 minutes if you exercised, or 45 minutes if it was a vasodilator stress, and image your patient. This is completely reversed if you were to do stressed first. As you know, this is kind of the protocol we use in our lab here. So we're actually stressing first at the lower dose, waiting 3 hours in between the stress and rest studies, and then giving a higher dose rest injection. And this is just a graph showing us the actual imaging protocols that we use in our lab, which is stress first, either 1 day or 2 day protocols, but pretty much going over exactly what I discussed in the last 3 slides. Why do we do stress first? As you know, there's been a big study that was published from our site. Dr. Chang was the first author, basically showing that there are a lot of advantages with stress-only imaging. First, when you compare it to a patient who receives stress and rest imaging, there's no change, there's no difference in long-term prognosis. So that's one very important feature. Then the second important features are, from a patient and throughput standpoint, by giving one single radiotracer injection, you significantly reduce the radiation dose, not only to the patient, but also the technicians who are coming in contact with these patients. You increase the throughput through the lab, and you're making a faster disposition for these patients as well. And of course, less radiation dose. So a quick word on dual isotope protocols. I don't think you will rarely see us doing technetium and thallium on the same patient. We only do this in viability cases, and the reason why it's not recommended as your go-to default for routine stress imaging is, again, exceptionally high radiation doses. All right, so we discussed a little bit about radio tracers, exercise, a little bit about the basics of our protocols that we use, and finally just a few words on what do these test results mean. And I know we're short of time, but I think I can get through this pretty quickly. So if you look at the diagnostic accuracy of SPECT, it is very similar to most of the other studies that are out there, in the sense that your sensitivity is around mid-80s, and specificity is around mid-80s. Now, what's interesting is that if you look specifically at exercise versus pharmacological, you will notice that there's no difference. So that should be very reassuring to you, that no matter whether you exercise a patient or you do a vasodilator stress, at least by our literature, there's no drop-off in diagnostic accuracy. Now, the literature has always shown that nuclear, as compared to wall motion-based techniques, has a higher sensitivity but a lower specificity. So one of the things that the nuclear in the nuclear lab we've always tried to do is to improve our specificity. I'm sorry, before we get to that slide, this is just a quick slide showing that no matter what vasodilator you use, again, it's roughly the same diagnostic accuracy. And this is just a slide showing you our diagnostic accuracy in comparison to other studies, large meta-analyses. Again, pointing out that SPECT generally tends to be more sensitive, whereas wall motion techniques tend to be more specific. So the question is, how do we improve specificity with nuclear? And there's actually a couple of different ways. It can be based on the radio tracers you use will help you improve specificity. If you're using gating, will help you improve specificity. If you use attenuation correction, which we use specificity, help you improve specificity. And then something new you've been seeing in our lab, the prone imaging, will help you improve specificity. So these 4 things we do routinely in our lab today. And why do we do them? The reason is because we're trying to improve our specificity. So this is just a study showing you that, with gating, how you can market, if you looked at the different agents, this slide shows you a couple of things. You can see the diagnostic accuracy of MIBI agents is higher than of thallium. And the reason, again, is because of, the poor counts that you receive with thallium. But the other thing it's showing you is that if you gate your images, you can markedly improve your specificity. So these numbers now start approaching those techniques that use wall motion-based techniques. These are just 2 slides showing you the data behind attenuation, correction, prone imaging. You know, I won't belabor the point. I think you guys get it. Sensitivity is unchanged. Specificity only proves if you're doing these 2 things. Okay, so diagnostic accuracy is one thing. Well, what about prognosis, right? What does it actually mean for my patient? Well, believe it or not, SPECT has data now, you know, from, you know, this technique has been around since the 1970s. So, you know, I don't think there's too many techniques where you can get prognostic information on multiple studies, almost 70,000 patients followed for 2.3 years, where if you have a low risk scan or a normal scan, your predicted risk is less than 1% per year. So, you know, we're talking 70,000 patients. I think it's a very, very powerful test. If you have a normal test, you are considered low risk and theoretically less than 1% per year. And then this is just another study, another meta-analysis performed showing you that a normal study here again demonstrates a less than 1% risk, whereas if your study is abnormal, your risk is almost 12 times higher. Now, just a little bit more about prognosis. This is the study I was referring to. There's been 2 out there, one by our own Dr. Chang and one by Dr. Duval. Large cohort of patients, stress-only imaging, very nicely showing you that if you do stress-only imaging and send patients home, they have no difference in survival compared to whether you're doing stress and rest imaging. So the rest did not add much. So a very, very powerful test. And then finally, you know, there's this, you know, and I'll, you know, we'll just spend a few moments on it. Yes, I mean, you know, like with everything else, the risk with myocardial perfusion imaging is really is contextual. That, you know, there are populations who have higher than 1% risk. Who are these populations? And these are patients you should be aware of when you see a patient with a normal nuclear exam. Now, that still means they're low risk. Theoretically, they're a lower risk group. You have a low risk finding. But if your patient was stressed with a pharmacological agent, if they're diabetic, they have chronic kidney disease, they're elderly, if they have a high Treadmill score, if they have coronary artery disease, their risks are not necessarily less than 1%. And there's a lot of data to show this. This is just looking at exercise and pharmacological stress. You can see if you have a normal study at pharmacological stress, your risk is 1.8%, whereas if you can exercise and it's normal, it's 0.6%. So just the fact that you couldn't exercise probably means you're a higher risk individual. Here is a study in patients with chronic coronary artery disease. You can see that compared to someone who has suspected CAD, a low risk scan still signifies a greater event rate than a patient who just has a normal study who has suspected CAD. This is a patient of study in patients who are greater than 85. You can see a normal study here, again, portends a higher risk than someone who's younger with a normal study. And then finally here, diabetics, you can see those patients who have diabetes. The green here is normal. They have a higher risk than a non-diabetic who has a normal study. So there are patient population groups where a normal study does not necessarily mean less than 1%. And then finally, data on the Duke Treadmill score, very important if your patient exercises to calculate this number, because this will very, very nice show you. If you have, and we see this all the time, if you have a normal perfusion study and they have a high Treadmill score, their risk is not less than 1%. Duke Treadmill score, they're actually 3.6%. So patient population you want to keep a close eye on. All right, so I think for the sake of time, the rest of my slides are really to, you know, go over how cardiac event rates increase as, you know, the severity of your abnormality increases. Is all kind of makes sense. The more ischemia you have, you know, the more worsening prognosis you have. If your ejection fraction falls, it also impacts prognosis. Anything in EF less than 50%, you can see cardiac death significantly increases. and how you can integrate ejection fraction and perfusion findings to better risk prognosticate the risk of your patients. So those patients who may have normal studies but significantly depressed ejection fractions don't fare as well as those patients who have normal EFs. It's everything you intuitively know, already know to think about, but just showing you, the actual studies that demonstrated this. And then just finally, a slide I think that's important for you guys to know is that, cardiac death really is dictated by your ejection fraction in all the nuclear studies. And whereas myocardial infarction is dictated by, your risk of MI is dictated by the amount of jeopardized myocardium you have, or your some difference score, or in other words, how much ischemia you have present. So ischemia correlates to MI, EF correlates to death. It's the most important message. And I will leave it at that for anybody who has any questions. I guess we can say that, this is retrospective data. We do use this on a daily basis. How we use, the perfusion abnormality when deciding whether we'll treat somebody medically or we'll treat them with revascularization. So a lot of this has been done, and we kind of have set this 10% cutoff in our minds of ischemia.